Welcome to the PT on Ice Daily Show brought to you by the Institute of Clinical Excellence. My name is Dustin Jones, one of the older adult faculty, and today we are talking about the missing piece in your plan of care. We gather lots of information. We've got lots of interventions to provide people. We can really change people's lives, but within the older adult population, we often see one group of variables that can dramatically influence outcomes that many clinicians are not even looking at, assessing, or necessarily aware of. And I want to spell out kind of a common scenario that I've experienced, maybe many of you all have experienced, is when you had this amazing evaluation that you take people through, you gather lots of helpful data, you identify the different deficits that you know are going to contribute to what this person wants to be able to accomplish. And then you go to give your intervention. You make your recommendations, you have your home exercise program, you're doing all the things, right? But when you go back to the next visit and the following visit, you're checking in on their HEP, you're seeing what progress they're making. You may not see much, right? They may not be fully participating. They may be having difficulty truly engaging in your plan of care. And oftentimes when we're talking about the older adult population, the contributing variable to us kind of spinning our tires in the mud theoretically is when we've failed to acknowledge and assess psychosocial resources. Many of us don't have time, right, to really look at a lot of these things, but they're going to be very, very influential. So I'm going to talk about what these psychosocial resources are, the importance of them, but then also how we can identify and screen these and influence them. So when I'm saying psychosocial resources or variables, what I'm talking about is emotional health, mental health in terms of cognitive health, spiritual health, social health. These four different buckets are starting to be studied pretty extensively in its impact and outcomes in the older adult population. And what's really interesting is we're starting to see a bidirectional relationship between someone's psychosocial resources and their physical health or physical outcomes. One in particular is frailty is being looked at in terms of the association between these two. And it seems to be there is a bidirectional relationship between these psychosocial resources and a diagnosis like frailty, meaning that, let's say, if I do have low psychosocial resources, let's say I have poor emotional health, or I have a cognitive impairment, or I have very limited social interactions, then that is going to put me at a higher risk of developing frailty. Then the reverse can also be true. If I am showing signs of frailty and all the physical kind of symptoms associated with that, probably decreased mobility, decreased independence, I've got some generalized weakness on board, I'm more vulnerable to situational stressors, these folks are also more likely to have fewer psychosocial resources, in particular the social resources and social connections. And so there's this bidirectional relationship that is going to influence our outcomes and what we're trying to influence. So we need to be aware of these, but I think we can use this bidirectional relationship to influence people's psychosocial resources, but then also their physical health and where they are on that spectrum of frailty. All right. So let's first talk about how we can influence those psychosocial resources in our context of working with individuals. And, everyone that watches or listens to this podcast, we're all in different situations, right? Like, I'm in a fitness facility for folks over 55. I'm spending a lot of time with folks, weeks on weeks on weeks, years on years on years. I've got a lot of time to influence folks. There's people on that listen and watch this that are in acute care, right? You're going to spend 30, 40 minutes with someone probably once, maybe twice, right? So we've got a wide array of influence, or time, I should say, but we need to have these things on our radar. So by and large, when we think about psychosocial resources, we need to be able to screen these and then make appropriate referrals. That is our kind of primary influence. And I think it's a very important job, because when you think about the landscape of healthcare, I want some of y'all to think about how much time you're spending with your patients, right? Like, if you're a home healther, you're in someone's home at least for an hour a week, probably 2-3 hours for several weeks, sometimes months. Like, I want you to think of what other healthcare provider can say the same, that they can spend hours in someone's home per week for months on end. And acknowledging that, you need to understand you have probably the most accurate perspective of that person's life and what they're dealing with and the struggles that they face. Even the outpatient clinician, right? You're spending probably a couple hours a week with someone over a period span of several weeks. Like other healthcare providers can't really say that. And so we have a very, very unique position in our healthcare system to where we do need to be able to identify and screen if something is going on. And so I want to give you three helpful screens here that you want to have in your back pocket. I acknowledge that a lot of y'all are not going to have time to run people through some of these different scales, but I do think it's helpful to be familiar with them. And we can ask some of these questions generally through our subjective or even throw them on like some of the paperwork that folks may fill out before the patient intake before you do your evaluation if you're an outpatient, for example. So the first one, looking at emotional health. One of the more common questionnaires that you will see, especially in home health, is going to be the PHQ-2, the Patient Health Questionnaire. It's a short form, 2 questions, and you're asking about the frequency of the following over the past 2 weeks. And so you ask them, have you had little interest or pleasure in doing things? And they rate how frequent that's been over the past 2 weeks. Are you feeling down, depressed, or hopeless? And they rate that. What do we do with that information, right? So what we do with that is we can make an appropriate referral to, let's say, a primary care physician, bring awareness to that, because we can trigger a pathway that can influence these depressive symptoms that we know are going to influence our outcomes. I know, antidepressant medication can get a really bad rap, especially in geriatrics, because some of the side effects, it can really influence balance and elevate risk of falling. But I've also had a lot of folks that have gone on antidepressant medication that have increased their physical activity, that have been more hopeful about certain things, and oftentimes they participate a little bit more. So I do think we can get some positive benefits from some of these medications in the medical care pathway that has been established, but could also trigger counseling, for example, especially when they don't have a lot of social interactions. That can be really helpful for folks to talk through some of their issues, have some type of counselor, therapist, give perspective and help them walk through a lot of times a very difficult time of loss, of transition. Can be very, very challenging. So that PHQ-2 is going to be helpful. I'm going to mention all these in the comments on Instagram. So you can search these. You can just search PHQ-2 PDF and it'll come up in a Google search. Next is going to be cognitive health. This is a huge opportunity that we often fail to even look at or acknowledge. And that's someone's cognitive capacity, that if we can get a cognitive screen, we can trigger some care pathways that are more effective earlier on in the development of a cognitive impairment. And it can also inform your intervention strategy in the sense of how you may communicate, what types of cues you may use, what complexity of your interventions are you going to use or maybe avoid, right? That we can kind of mold our communication intervention style to someone's cognitive ability to maximize what they're going to get from that. So what we recommend for many folks in terms of a general cognitive screening is the mini cog. It's relatively sensitive to cognitive impairment, in particular, Alzheimer's, dementia, and it's real simple. You have people repeat 3 words, then they draw a clock, and you have them draw the hands on the clock after they put the numbers in, 10 past 11, and then you ask them to repeat those 3 words that you mentioned on the front end. And it has several lists of 3 words that you can give those folks. Very easy, very simple, and you can identify a cognitive impairment that's going to influence your intervention, but then you can also make an appropriate referral, which can be really, really helpful. And then the third one that I want to mention, and something that I think we need to be more and more aware of, that the research is pretty wild to see some of the negative influence that this variable can have on our lives, and that is social health, the number of social interactions I have, and the depth of those relationships. A really helpful scale that's very easy to run is the UCLA 3-item loneliness scale. So it doesn't necessarily assess like social isolation, which is more about the quantity of social interactions that you have. It goes a little bit deeper to kind of the depth of those relationships, right? Are they fulfilling you? Do you feel like you're getting a solid connection, a high quality connection with individuals? because that can be very important in terms of health outcomes. So this loneliness scale, it's also looking at the frequency of the following, but you basically ask, how often do you feel lack of companionship? How often do you feel left out? And how often do you feel isolated from others? And if people are more isolated from individuals, they on average are going to have around 20-25% increased risk of all cause mortality in the older adult population. That's a really significant stat. And so we can identify that and then also use that information to try and connect them with other individuals. All right. So screening is going to be really important. We can refer and hopefully influence some of those psychosocial resources and variables that we know can influence their outcomes. All right. Now let's look at kind of the other direction of that bidirectional relationship. And this is where we probably spend more of our time. How can we influence health and function and physical capacity that is going to influence their psychosocial resources? And so, what we really need to think about here is exercise has been proven to be very, very helpful for depressive symptoms, for cognitive health, for social interactions, right? So, just getting people moving is going to be helpful. And in a lot of these scenarios, that is our main goal, right? I may not be taking people through a bunch of meaningless, seated, isolated joint kind of Therex routine that I hand out to everyone, right? That is not going to influence a lot of these variables as much as, let's say, a very meaningful activity or exercise, like a deadlift or a squat, because we can translate that to so many meaningful activities and functional activities. I've also may be really, really focused on getting them moving, but really enhancing their ability to move throughout the community, right? Their independence in their gait, able to handle different thresholds, curbs, steps, multitasking, cognitive, motor, dual tasking. We can build in some of these variables to improve their community mobility. And then ultimately to train in a manner that we maintain their independence as long as possible. That if we're able to promote physical activity in that manner, you're going to likely improve depressive symptoms. You're going to influence cognitive capacity, but you're building up their capacity to socially interact with other individuals. You're probably giving them the confidence to leave their home, to go out to whatever group that they may have been going to a long time ago, or try that new hobby or the thing that they've been wanting to do. You're making them more resilient in that scenario. So I like to think about whatever they enjoy, what is meaningful to them, what activity where I know they're going to start interacting with people, what's something that would bring joy to those folks, and pick a lot of our exercises and training regimen around that to increase the likelihood that they're going to be able to execute on that particular activity. I think we need to be very mindful in that regard, but we also need to be very mindful of what resources are available from the community standpoint. This is where we need to know what maybe community-based exercise classes are in the area, right? It may be a Silver Sneakers. It may be a Stave Off. It may be a Stronger Life, for example. Some community in your area that is welcoming and can accommodate a lot of the complexities that older adults bring to the table. Do you have people, right? Do you know someone that is serving these individuals? And if not, maybe you should be that person. Maybe you should start a program a few times a week to bring these people in and encourage some of those connections, right? At Stronger Life, we also think about how can we encourage community from organizing events, run or walk clubs, supper club, all kinds of different things where we're intentionally getting people together because we know that's really, really healthy for them. So I want you to think about this bidirectional relationship between psychosocial resources and the outcomes that you care about. We need to be able to understand and assess those psychosocial resources. A lot of time it is going to be a referral, right? But we need to understand if they are relatively low in those areas, it's going to influence your outcomes. And you oftentimes can do something about it. But then we also need to think about how we're building people's physical health, their physical capacity, and how that is going to influence these psychosocial resources as well. And if we have that in mind, we can build these very helpful programs that can build physical capacity, that can build independence, that can build confidence to engage in meaningful activities that are likely going to improve mood, influence cognition, and increase social interactions with folks. And we're win-win-win all around, right? And that's a beautiful thing when all of those things come together, that we can influence the physical side that we often focus on, but ultimately influence their whole lives. And that's what we're about, right? We're here to change lives, not just change pain. I think in the older adult population, these psychosocial resources are a huge opportunity for us to really level up. All right. I appreciate y'all listening and watching. If you are curious about those 3 different scales that I've mentioned on Instagram, I'm going to put those in the comments, and then you can just search those with PDF. I would put that in there, and then you'll have that, and you'll be able to print that off and use that with your folks. All right. You have a lovely rest of your Wednesday, and I will talk to you soon.